Candidiasis, basically, I'll go into the definition of it. It's also called yeast overgrowth syndrome is the other name for it. Chronic candida is another name. So there's a few names for it, but it basically just means overgrowth of candida in the intestinal tract and all the resulting effects that has. I have two handouts that I gave you, and I'll kind of touch on them in a minute, but one of them is this. It's a way to score yourself to see what your risk is or how likely it is that you have a chronic problem with candida. And that was developed by Dr. Crook in his book, The Yeast Connection. He was one of the first doctors to really bring out the importance of candida and make it well known to the rest of the medical profession. And so this questionnaire is the one that's pretty much everybody uses that does a lot of this, or at least something like it. And so if you take that test, and depending on where you score, you can get a pretty good idea whether you have a problem or not just based on that. It's fairly accurate. It's been tested in a lot of people. And then the other one is called Are You a Sugar Addict, which, you know, a lot of us are. So that's something that I think is a big issue that we have in our country today, since we all consume about 150 pounds a year of sugar. So, you know, there's a big problem with that, and that contributes a lot to this problem. And so I thought that was appropriate to give that to you so you could kind of look that over and see where you fall in on that. Okay, so we'll go ahead and get started on this. All right, so one thing I just want to kind of touch on is just kind of when you start talking about something like this, if you look at like what my background is, and I have a very conventional background, you know, in conventional medicine. I didn't graduate from a naturopathic medical school or from anything like that. I graduated from a totally conventional medical school, so all my training is completely conventional. And before I was a medical doctor, I was a veterinarian, and that's not quite as conventional as human medicine, but it's still pretty conventional, you know, a lot of it. And a lot of it's influenced by the pharmaceutical companies. And so you really, you know, in order for me to get to the point that I am today, I really had to break out of a lot of that, you know, a lot of those things that I learned and everything that were so conventional. It was really hard to kind of get into this type of thing. So when you talk about this kind of stuff, it's really, you know, it's hard for some people, like if they're trained like I was trained, it's hard for them to relate to this and to really get a grasp on it, and they kind of immediately want to reject it because they say, well, there's not that much scientific evidence to support this. But when in fact you really look at what kind of scientific evidence do they have to support a lot of what they're doing, and it's really not that great. So I brought this up that, you know, when they looked at like infectious disease evidence, so this would be like for treating any kind of infectious disease that we treat, like in the hospital or wherever, you know, in a conventional practice, they looked at all the guidelines, and they actually analyzed over 4,000 individual recommendations, and they looked at all those recommendations, like just recommendations like, you know, what kind of antibiotics do you give for pneumonia, or what kind of antibiotics do you give for urinary tract infection, or for intestinal infection. And basically when you look at this, you have three levels of evidence, and this is what they use throughout medicine to determine whether or not something has validity, or, you know, what is the evidence behind the particular treatment. So when we look at level 1, that means that these are controlled, randomized studies. That means that they randomly select patients. The person who's studying it doesn't know which patients are being selected for what. They're just randomly selected. And then they do a controlled study, you know, so they have one group that doesn't get the particular treatment and one group that does, and then they do the comparison. That's a level 1. So that's supposed to be the highest level of evidence. So with all the recommendations that they have, there was only 14% level 1. Now level 2 is kind of the same as level 1, except they don't randomize them. They know kind of which ones are in the control and which ones aren't. There's not the randomization, but that one, there's only 31% of the recommendations. So the vast majority, over 50% of the recommendations, like when you go to see the physician for like whatever you're complaining about, if it's an infection, you know, basically over 50% of the time, that recommendation is going to be based on nothing but expert opinion. So that's, you know, kind of what we're looking at. So, you know, with what we have with Candida, we do have some studies that are controlled, and I actually gave some references to that. And, you know, I wouldn't put them in the level 1 evidence, but we can at least get to level 2 on some of these. But yet, if I go and I talk to somebody that is, you know, in a conventional medicine about chronic candidiasis, well, it's not recognized as a distinct syndrome. So it's not treated as such. So you won't get treatment for this. Like if you went to Mayo Clinic and you told them you had chronic candidiasis, they would just say, well, I don't really know what that is, or I don't really think that really matters because, you know, that's probably not causing your problem because they don't recognize it. So basically, it's not recognized as a medical syndrome by conventional medical experts. So, you know, that it's just not there. So, if you look at it, though, in naturopathic medicine or in integrative medicine, it's widely recognized as a problem, and it has been for quite a while. And what we see with Candida is that when Candida overgrows, it can cause a wide variety of symptoms in every system of the body. So the ones that are most commonly affected are like the gastrointestinal, the genitourinary, the nervous, and immune systems. And these are all the most susceptible systems. All right. So when I say commensal, that just means that it's kind of friendly. It can be, you know, sort of friendly in the body. It doesn't really cause any problems in a lot of cases. So normally, like if you take somebody who's healthy and doesn't have a lot of issues, like you can normally find Candida, you know, in some of the warm areas, like in the gastrointestinal crevices and the vaginal tract in women, and it doesn't really cause any disease there. It's only when it starts getting overgrown and the immune system doesn't get it into check that it starts causing problems. With severe disruption of, well, basically when conditions promote the overgrowth of Candida of the immune system, or the immune system is compromised, that leads to overgrowth. And then you can get disruption in this intestinal barrier, which we'll talk about later. And then that can lead to problems with absorption of the yeast toxins, because the yeast does produce toxins. So when it's overgrown in a large amounts, it can significantly increase the toxin load on the individual. And then that can transverse the gut wall and lead to a lot of symptoms, as we'll see in a minute. The other thing, the yeast syndrome, I alluded to that. It's called yeast syndrome, chronic candidiasis. It's also called Candida-related complex. So, what about chronic fatigue syndrome and candidiasis? So a lot of patients with candidiasis have many of the same symptoms as those with chronic fatigue syndrome. And so a lot of times these patients will actually improve with treatment with an antifungal agent. Just simply treating them that way will lead to improvement. In a lot of cases, unless you do everything we're going to talk about, it won't lead to like permanent improvement. But if you take somebody with chronic fatigue and you give them diflucan, they'll feel better sometimes, you know. So there's evidence that Candida albicans infection of the mucous membranes depresses T cell and natural killer cell function. And there's a lot of similar abnormalities found in chronic fatigue syndrome, so that these cells, these immune cells, are somehow compromised, and they're depressed by the Candida albicans. So it's proposed that candidiasis may lead to this, and there is some evidence, there's some factors that they found that do that. So what about intestinal inflammation in candidiasis? Recent studies show that high-level Candida colonization is associated with several diseases of the gastrointestinal tract. And this results from animal models argue that Candida colonization delays healing of inflammatory lesions, and that inflammation promotes colonization. So these effects will kind of create a low-level inflammation, and then what happens is that the fungus just gradually grows and grows and colonizes more and produces more inflammation. So if we look at things like inflammatory bowel disease, so inflammatory bowel disease is like Crohn's disease or ulcerative colitis. That's a type of inflammatory bowel disease. And this colonization, or when the candida like grows inside of that along the intestinal tract there, it's associated with these elevations in pro-inflammatory cytokines. And so that's just one of them. It's called IL-17. There's a whole bunch of those interleukin type cytokines. They're numbered with different numbers. And thank God they didn't try to name all of them, because it would be really confusing. But so they put numbers on them. And so therefore the effects on these levels may underlie the ability of candida colonization to enhance inflammation. And the thing is that because candida does colonize a lot of people's guts, there's a high potential for it to cause inflammation and impact a lot of people through this method. So one of the common things that we can also see with candida is, you know, that when a lot of you have probably experienced being treated with antibiotics, and then you end up with a yeast infection. And basically what that does is it causes candida overgrowth in the gut, and the reason for that is because the antibiotics will kill off some of the good bacteria that are in the gut, which are normally keeping candida in check, because they're kind of like suppressing the candida's growth. And when you treat them with antibiotics, then the candida starts overgrowing. And so there's a study that I alluded to here where they looked at chronic diarrhea in elderly patients treated with antibiotics, and they tested negative for C. difficile. Clostridium difficile is another bacteria that's in the gut that if it starts overgrowing, it starts producing toxins too. So you could see the same thing with some bacteria too that will produce toxins. It's just that I don't think that the bacteria are quite as persistent, maybe not as smart as candida in some ways, but but these patients that were getting diarrhea, like when they gave them nystatin, they got better. So that was just a case where candida overgrowth was causing diarrhea. So a lot of times you can see that too. You know, with the antibiotics, when people are given antibiotics and they get diarrhea, they may not be getting diarrhea just because their bacteria is knocked off. It may be that they're getting candida overgrowth in their GI tract. And so and that happens, especially with people with chronic fatigue. When they take antibiotics, you'll get candida overgrowth, and their fatigue will get a lot worse from more candida overgrowth. So what about candida and chronic sinusitis? That's another thing where we see candida a lot, is in chronic sinusitis. And they did a lot of different washings and stuff, and there's some studies that have been done on that show that candida is present a lot of times in chronic sinusitis. And if you look at those patients with chronic sinusitis, and I've had this experience in my own practice, if I put them on a candida elimination diet and start treating them with some kind of antifungal treatment, they start getting better, and they start getting some resolution of their symptoms that they never had before. Because the standard treatment is like to just keep throwing antibiotics at it. And the thing is that even if you look at the medical literature on that, and it shows that it's not effective to treat chronic sinusitis with antibiotics. And there's a lot of things that aren't effective. Again, we go back to that level 3 evidence where it's expert opinion to give these things, and that's the best they have. And sometimes they don't even have that. And we're treating a lot of these infections with antibiotics that don't really need antibiotics, and they're not doing them any good. So what about, there's other cases where patients with chronic urinary frequency, like you look at these patients and they may get diagnosed with like interstitial cystitis or just like no diagnosis, just increased urinary frequency. And you test their urine and you can't find any bacteria in it at all. And you don't even find yeast in it. But really there is a problem somewhere with yeast because they respond to to treatment with anti-yeast medication like caprylic acid, which is actually an extract from coconut oil that works really good on yeast. So this is kind of interesting. I just kind of threw this out, like, you know, have you ever heard of anybody getting drunk without drinking alcohol? And this is actually a piece of it right here. So basically, this person was just treated with antibiotics. So he was given, like, I think he was given amoxicillin, augmentin or amoxicillin with clavulanic acid. And when he was treated, he started having these symptoms where he was like, you know, kind of mentally, you know, cloudy thinking and kind of acting like he was drunk. And so basically what they did is they stopped the antibiotic, and he was also eating a lot of sugars, a lot of simple sugars. And so they stopped that diet, and then the blood alcohol, they were finding blood alcohol in him, you know, and he was saying he wasn't drinking. And so when they stopped that, then the blood alcohol level went down. And so they decided, well, was this really caused by this? So they gave him the antibiotic again, and gave him a sugar-rich diet, and indeed his alcohol level went back up. So basically what was happening here is the yeast is fermenting simple sugars and everything into alcohol. And it's well known to do that. And that probably is something that's happening with our chronic fatigue patients, is that when they're eating sugar, they're given some source of fermentation for the yeast. The yeast will ferment it into alcohol, and that makes them feel kind of, you know, tired and sedated, and, you know, causes cloudy thinking and just kind of a lot of the same things you get when you know, drink too much alcohol. So the other thing that it does is it ferments things into acetaldehyde. So that's like if you take alcohol, like if you, well, you know, if you you leave the yeast too long in wine, what happens, right? It becomes vinegar. So, and what's in vinegar is acetic acid. So basically what yeast will do is it will take alcohol too, and it will ferment it into acetaldehyde, which is very toxic, and causes a lot of sedation and stuff, and makes a person feel achy and all kinds of things. So it's like putting vinegar in your blood almost, basically. So how do we diagnose chronic candidiasis? As I noted, like I pointed out this questionnaire by Dr. Crook, and that's probably one of the main things we do to diagnose it. Now, the thing about it is that, you know, there are some tests you can do, and there's several tests that have been developed to diagnose candida. But really, they're not all that accurate all the time. Like, I could take somebody that has a score of like 180 on that yeast test, and it's like they got obvious yeast. They got, you know, they look like they got hyphae coming out of them, you know. I mean, they're totally with yeast. And you'll do like a test on them, and it won't be positive, it'll be negative. You know, you'll do like antibody tests on them for yeast, and they're negative. And so it doesn't always work, and the reason for that, part of it is because Candida produces products like we've seen, like that, you know, IL-17 and everything, and some of these things can suppress the immune system, so it suppresses the actual immune response to the organism. So they're really pretty smart, you know. With their toxins and everything that they produce actually, you know, induce more proliferation or more growth. And so you can't really depend on blood testing. You can do comprehensive stool testing, and sometimes you'll see it there, and you'll see heavy growth of yeast. But even in that case, sometimes you don't, and that's because the yeast isn't really coming out like it should. It's like, you know, the yeast gets kind of ingrained into the wall of the bowel, and they've showed that the yeast will actually form biofilms over the top of it that protects it from things, and so it won't like always slough off into the stool that much. I mean, you'll get some, but you know, it's not as much as you would think. And so you may get a test that just shows a few yeast, you know, or rare yeast, and there's not a lot, but they still have a heavy overgrowth. And it's interesting with some of these biofilms, and I didn't really go into this, but these yeast and some bacteria do this too, but they've gotten to where they're really smart, and you know, it's almost like you're talking about some kind of a, you know, a weird alien thing or something. But they take like, and they make these biofilms, and they put metals in them, like heavy metals, like they find mercury in them, and they find lead in them, And then the other thing that they do is they weave fibrin. Like fibrin is like a connective tissue, like it comes from inflammation. It's formed by the body that's made out of collagen. And they take that fibrin and they actually weave a lattice. I mean, it's like a real elaborate lattice. It's like crossed here and making all these things. And then they got these metals like stuck in the middle of it. And so you're like, with people that have this, trying to get at that can be a real challenge, you know, when it's really chronic and you're trying, like in the sinus thing, that's where you find a lot of it is in the chronic sinusitis, and you find these really heavy-duty, biofilms, these barriers, or, you know, that they put up. It's makes it tough. So what are some of the predisposing factors to chronic candida? Well, the biggest one that we have. Well, just back to this, just a minute. Just one of the points that I want to make. Okay, so I went through all that about you can't test. So basically the main way that this is diagnosed, or the best way to diagnose it, is first you have to have somebody that knows about it, a physician that's privy to it and is well, you know, versed in it. And then it's that physician's clinical impression that comes, that's the most important in making the diagnosis. And that comes through like using this questionnaire, which is really helpful, and then getting a good history, because you just can't, because if you go to somebody that doesn't know about it, what they'll do is they'll say, well, we did all these tests on you and you don't have any yeast anywhere, you know, but the person is like got yeast everywhere, but they can't find it, you know, but it's there. So that's why you have to use the clinical impression is so important, and it's hard sometimes for people that are conventionally trained to wrap around that, you know, because it's like you always have to have this test or something that proves you're right. So what are some of the predisposing factors to candida? So the big predisposing factors, the number one thing is like a lot of antibiotic usage, okay? So that's going to be the most important factor. And what I've seen, and I'll just use my wife as an example, and she won't mind, I don't think, but she's not here, so no. But anyway, she'll hear this recording later, though. So anyway, the big thing about it is, if they've had antibiotics, like she had antibiotics when she was like less than a year old, she had like 3 months of IV antibiotics because she injured her leg and she got an osteo in her bone. And that like messed her gut up for life. And she couldn't figure out, I mean, she had all kinds of issues. She ended up with the diagnosis of MS when she was like 18, which was probably related. I mean, most certainly related. And I can show you, I'll go over why that was. And she's had just one thing after another, and we've worked on this yeast, and we have got it. She's a lot better than she ever was, but she used to have all this aching and muscle aches, and her joints would swell, and we thought she had rheumatoid arthritis. And she probably basically did, in a way, you know. But once we started doing some candida elimination and she really started working on the diet and everything, we really got that under control. She still has issues, and she still has to work on a lot of things. But, you know, she's like 90% better, you know. And it was all because of those antibiotics. I could trace it right back to all those antibiotics, you know, messed her gut up so bad. And a lot of people have had that, and they don't know why they're sick all the time, and part of it is because of that. So, you know, one of the other things I see, like this post-surgical thing, and you'll have a patient who had a bowel, you know, surgery, and then they'll, you know, have a leakage, and then they end up on long-term antibiotics because of that leakage, and that, you know, and the peritonitis, and they'll end up with all kinds of candida overgrowth. And I've had patients, you know, that have been, you know, young patients in their teens that were on Prilosec for 3 years, you know, and it's, you know, why is this kid on Prilosec? You know, he's like 17 and he's been on Prilosec for 3 years. So he was on this acid blocker because he kept getting all this reflux. It was terrible. And because he had this ruptured appendix, and he was in the hospital for a month on IV antibiotics. So, you know, once we like started treating the yeast and eliminating its food sensitivities, it's like bang. I mean, quickly got off the Prilosec and has never went back on it, and his gut's been pretty good. So, you know, it's things like that. There's a lot of stories like that happens. So the other thing that happens is that we look at this repeated use of viral antibiotics to treat viruses. So, you know, I mean, what kind of evidence do they have for that, Steve, to treat viruses with antibiotics? You know, it doesn't work, you know, I mean, but everybody does it. So it's like, and then you end up, you know, with some people, it's like, okay, maybe it doesn't affect them that much. They have a healthy gut and it probably affects them some, but, you know, they don't get chronic candida, but some people do. So repeated treatments with cortisone-type drugs is the other thing that can be a predisposing factor. So because that suppresses the immune system, number one, and so that the yeast can start overgrowing. So that's another predisposing factor. And then the long-term use of proton pump inhibitors will cause it. And the reason that does is that because it suppresses the acid, you know, in the stomach, and you don't have any protection against candida infection is one of the reasons. But we'll go into that some more. And just, yeah, you know, the stomach acid is really important, and restoring those levels can be real helpful in treating it. Leaky gut, and I'll go into this a little more at the end of the, towards the end of the talk, but this is like a really big deal, okay? So this thing really helps if you understand the leaky gut concept and, you know, how this contributes to everything, because this is like the underlying problem in so many diseases. And all your autoimmune diseases a lot of times have as a basis this problem. And basically, you know, what happens here with this is that, I don't know, can you guys see on those slides, can you see, I kind of picked this slide out for a reason. Can you see that, those, these little hyphae and little round thing there? You can't really see it. Anyway, it's supposed to look like yeast, okay? Basically what it is, it's a flower, okay, is what it is, but it has these buds coming out from it. Okay, and so that's what candida, you know, it forms these hyphae, they call them. That's like these stems that come up. And the stems come up, and then as the stem goes out, then there's a little bud there present. That's the budding yeast, okay, and that's where it reproduces from. The hyphae, you know, you'll read in books and everything, and like, you know, what is the purpose of the hyphae? And sometimes they said they really haven't determined exactly what the purpose is. But, you know, I think it has to do with transporting nutrients, one thing, into the yeast, you know, the hyphae, I think. And then the other thing these hyphae do is they I think one of the big things they do is they protect the yeast, and they allow it to like get into nooks and crannies and stuff and attach itself more solidly. So what this yeast will do and is in the gut wall is it will take those hyphae. It'll start, you know, the yeast can exist in different forms. It can exist in a form where it has the hyphae, and then it can exist in a form where it's just the bud. It's just a little round, you know, yeast cell by itself. But then it can start growing these hyphae, and when it grows a hyphae, these hyphae can actually grow into the intestinal wall, and they will grow in between the cells, and they'll disrupt the connective tissue. So what that does is that disrupts the barrier in the gut, like when that hyphae gets in there. It also makes it hard to treat it, a little harder to treat it too, because it's actually, burrowed itself into the gut wall. And so what it does too is that it produces toxins, the candida does, and it produces, like we'll see in a minute, 400 different toxins that have been isolated from candida. So these toxins can basically, what they can do is leak through that area where it's damaged, and they can get into the system, and then that's where they start causing a lot of symptoms and everything, with muscle aching and fatigue and cloudy thinking and all that. So stress, one of the things is that this is kind of interesting too, how this works, in that if you get like the gut wall, the lining of the gut wall, it needs to have a lot of nutrition, okay? And there is a lot of nutrition that goes there. Like all of us are sitting right here, and we probably just got done eating that not too long ago, most of us. So basically, you know, you still have a lot of blood going in there to your gut and everything to get those nutrients out and to supply the gut, you know, with what it needs and everything for digestion. And so there's a big blood supply into the gut. And that's important too from the standpoint that the cells in the gut turn over every 24 hours. So every 24 hours, like, your cells will like turn over to new cells. Like, you slough off the old ones, you get new ones. Okay, so what happens is if you get stressed out, the body, just as means a protective mechanism, will take the blood supply away from the brain or from the gut and like shunt some of it to the brain and to muscles. It'll put a lot into muscles and stuff because with stress, you know, I mean, in the old days or whatever, you know, if you think about what happened to us when we were cavemen, or whatever, as evolutionary, right, type thing, where, you know, when we were, you know, got stressed out, we had to do something, you know, we had to run from wild animals or whatever, right? So that's the whole concept there, that the blood needs to go, it goes to the limbs so that we can move and we can start doing something. Well, when we're stressed out chronically, we don't really need to be doing that, but our body's still doing it. It's still bringing blood into our muscles and stuff for action. But it takes it away from the gut, and then what happens is that it doesn't get nutrition, and then the gut barrier, what happens is those cells don't get the nutrition they need, and they don't turn over right, and then they're not healthy, and so you're left with unhealthy cells lining your digestive tract, and then they become more leaky, okay, and they leak toxins. Does that all make sense, or is that... All right. So that's kind of important to know how stress, because stress is like a really huge issue, obviously, today. So how do we heal the leaky gut? And we'll go over that. I'll just go over that a little more. I'm not going to go through all this right now. But we have to remove candida. That's essential to get healing, okay? Or whatever else other organisms might be there that might be causing the problem. So... but even though, you know, if we remove, like with people, some people will get like treatment for chronic candida, and they'll like get better initially, and there's different reasons why they relapse and stuff, you know, but it may be dietary and that type of thing, you know, going off the diet too early and they relapse or whatever. But one of the big things that will cause a recurrence is that the leaky gut problem is never really fixed, okay? And they may not even have candida. They may get rid of the candida, but they still don't feel well because they still have this leaky gut issue. And so they're still leaking toxins and stuff, and so they still have a lot of the same symptoms. So it just goes, what I want to emphasize is that has to be addressed, and we'll talk about, there's a little bit on the protocol we use and stuff for that. MSM can be one thing, L-glutamine, you know, essential fatty acids, other nutritional factors. You know, and the other thing, if you have leaky gut, you know, you get a lot of food sensitivities, you get food allergies, and you get these reactions going on in the gut wall, and that's actually a whole nother subject you could give another lecture on, you know, because it's really involved. But anyway, the leaky gut thing, like if that's going on, you know, you're going to have a lot of food sensitivities, and if you don't eliminate those foods, you're going to keep getting reactions, and then you'll get more reactions to other foods too, because your gut's still leaking and the foods are leaking through the gut and causing a reaction. All right. So what about candida toxin production? Like I said, there's over 400 different mycotoxins. We've seen an example of one, you know, which is alcohol, and that guy was like actually drunk and he wasn't drinking because the yeast was fermenting it. Acetaldehyde is the other one that causes sedation. The other thing that's interesting, you know, the yeast contains these decarboxylases. So these are enzymes that convert, or they actually putrefy amino acids. So they actually make them into these vasoactive amines. So these amines that they get made into actually can dilate the blood vessels, and they have vasoactive properties. And then the other thing they do is they actually give off some really bad odors. I mean, like the one's called putrescine, you know, it's called that for a reason, so that, you know, the stuff that the yeast actually makes, or, you know, that's one of the symptoms that can be with yeast overgrowth, is really odoriferous flatulence, you know, so it's a problem that way. So the other thing is this gliotoxin is one of the toxins that they've shown that suppresses the immune system. And it interferes with actually the energy production at the cellular level, and then that results in decreased WBCs. So you could see like chronic low leukopenia, chronic low white count. And then chronic fatigue, a lot of times you'll see that the patient will have a suppressed white count. And this can be one of the reasons, is that the yeast is causing a suppression. And there's some studies on that that validates that. There's more than that one I put up, but I did reference one of them. Okay, so the liver, that's another big issue in chronic candida. The liver has to be capable of adequately detoxifying the candida and adequately detoxifying during candida elimination, because when you get candida elimination, if you're going to go and you're going to start killing, the liver's usually not working well when you have candida overgrowth either. It probably never is working well. But basically what will happen here is that the candida produces all these toxins, and when you start killing the candida, it's going to release more toxins from the cells. Are going to come out, and if your liver's not working well, you're not going to get rid of those toxins. They're going to go in the bloodstream, and then they're going to float around and go everywhere and not go out where they should go. So it's really important to make sure that we support liver function. So here's some things that will indicate if a patient has impaired liver function. One thing is if they're more than 20 pounds overweight, if they have diabetes, if they have gallstones, heavy alcohol use, psoriasis, any kind of synthetic hormone, like birth control, it's a given that they're going to have some liver decompensation, because the liver has to work, every day they're taking a pill that's a synthetic hormone that the body has to get rid of, and it has to get rid of that through the liver. So, and this is well known. You can read the insert on the birth control pills, and, elevated transaminase, elevated liver enzymes is a common side effect or adverse reaction. But the thing with our liver testing is that when you look at like just doing a liver test that you get in the lab, that doesn't really tell you if your liver's really functioning that well. If those tests are bad, you got some major liver damage going on. Okay, so there's more sensitive tests to look at the liver if you want to, but just because you have normal liver enzymes doesn't mean that your liver's working great. So that's one thing, if somebody's on birth control, and that also puts people at risk for yeast too. Yeast overgrowth is birth control pills. So high exposure to chemicals, solvents, illicit prescription drugs. So the thing is if somebody's on a drug, the more drugs that somebody's on, the more their liver has to work. Where are those drugs going to go? Most of them go through the liver, and they have to be detoxified through the liver. Some will go out through the kidneys, but a lot of them go through the liver anyway. And so the more drugs somebody is on, the more their liver has to work to get rid of those drugs. And so, we know now that if somebody's on like more than, what is it, Steve? Like there's a number, like 10 drugs, they almost definitely have an adverse drug reaction going on, somewhere. So there's a number, and as the more drugs you're on, the more adverse drug reactions that are possible. So that the problem we have is when these drugs are metabolized, that's where the problem can be. Because like you could take Tylenol, like Tylenol is like no big deal. It doesn't cause problems. It doesn't by itself. It's not toxic. Acetaminophen is not toxic to the body. But when it's toxic is when it goes through the liver and it's converted to its toxic metabolite. And then it becomes toxic. So, and that's with a lot of drugs. They're not really necessarily toxic by themselves, but when they go through the liver, they become toxic. And some people, because we know now that some people have genetic abnormalities that they don't metabolize these drugs properly, and that's why some people, they take a drug and it's like, man, it sends them to the moon, or they're just like sick for 15 days, and it's like somebody else took the drug and they're fine. It's because they have a genetic problem in metabolizing that drug. And we can do tests now to look at that, at these different genes and stuff, and see if that person has that problem. But that can be a big issue with liver problems, is how many drugs somebody's on. And if somebody has hypothyroidism, I just noticed that was a typo there. It should be an H after the T. But anyway, hypothyroidism, that's another thing that can cause problems with the liver, because you don't have the energy you need to run the liver detoxification pathways. And so liver support during Candida elimination. So it is important, I think, to think about that, to try to support the liver when we do Candida elimination. And sometimes it could be just as simple as maybe even just taking milk thistle could be helpful. You know, there's other things you could do, but I think we should think about doing that when we do Candida elimination. So I just want to kind of, finish off now just talking about our treatment and kind of the things that we need to think about when we're treating chronic candidiasis. So basically, what I have here is a 4R program, and that's kind of something that's been used, I guess, throughout naturopathic integrative medicine and stuff. And it's kind of what a lot of people use, and it makes sense. So basically, when we look at this, and you can do this for not just chronic candida, but for even though chronic candida is present in almost all gastrointestinal problems, it works for any GI problem. So basically, this 4R program is a comprehensive program for optimal gastrointestinal health. So we have these: remove is the first one, okay, and then replace, repopulate, and repair. Okay, so I'm going to go through each one of those and kind of tell you what I mean by it. So when we remove, we want to remove the pathogenic organisms. So in this case, what we want to remove is Candida. We're talking about Candida. But some cases we may be dealing with H. pylori, or there can be other bacteria involved, or that's coexistent with Candida. There may be parasites, like, we're starting to see. Well, I guess they've been seeing it for a while, but it's maybe recognized more now as chronic giardia. Like, people can have giardia, for years and not really know it, and it's causing issues. So, you remove those. And so then the other thing you need to do is remove the food sensitivities, because there's almost always going to be food sensitivities in patients with this. There always will be. I shouldn't say almost. There always will be, because of the leaky gut problem. And so the most common, you should do a test, I think, in most cases. I like to test, people to see, because I think it really gives you a better idea. And people are reacting to different foods depending on what they're eating, but these are the common ones. The common ones are wheat, baker's yeast, brewer's yeast, corn, cow's milk, soy, and eggs. And when you talk about food sensitivities too, there's a lot of different reactions that can take place in the gut. And so sometimes we do the IgG test, which tests for one type of antibody against food, but there can be other ones, like IgA can be a reaction. There can be just the cells that will react against it. That's what the ALCAT tests for, just immune cells like T cells response, the cell-mediated response to the antigen or to the food. But actually the gold standard, but I hardly ever use this in my practice, but if you have time and the patient's willing, the gold standard is to take and put a patient on a total elimination diet. So, and with that diet, you basically just put them on lamb and rice, for like 2 weeks or so, or maybe not that long. Maybe you could do a week, I don't know. But you do, anyway, a time period, a week, 2 weeks. And I know it's hard to do this. So, and then the person is supposed to take one food at a time and introduce it and see if they react. Okay, so that's why I don't do it. It's just I can't get my patients to do it. So anyway, so we do the blood test and everything and look at it that way. So at least 60% of Americans have significant food sensitivities. It's slowly developed by repeated eating of the food, usually. It's usually something you like, and, you eat a lot, and a lot of people will crave the foods that they're really sensitive to. So, people that have yeast, candida, they usually crave, yeasty breads and yeasty rolls and stuff like that. It's kind of interesting, but that's what they kind of crave. And these are things that they're sensitive to. They have food sensitivities to baker's yeast a lot of times and brewer's yeast. So, anyway. All right, so in the Candida elimination diet, what we do with that is we want to get rid of the food sensitivities, but we can't just continue, so the person said, well, I'm not allergic to cane sugar, so I can eat that. No, not really. If we want to get rid of candida, we can't eat that, okay, because that's what candida likes. That's what it eats. So, and that's why we, make wine out of yeast and sugar, So that's what it likes. So, that's what it's going to do in you. So we got to get rid of the sugar. And so we got to eliminate anything that's rapidly converted to sugar that feeds candida. So if we really want to get on top of this, we got to get rid of alcohol, baked goods, breads and stuff. Eliminate high sugar fruits and fruit juices and white potatoes and stuff like that. They talk about and some people will just you'll eliminate all this stuff, but also, you can't, if you want to eat apples or something, you can't eat 10 apples a day, because you're going to get a lot of sugar from the apple. You won't get as much if you eat one, But you look at 150 grams of carbohydrate kind of being the cutoff, and what you take in when you're doing the first part of the candida diet. So, and I think the best way to do this, I used to put people on diflucan and nystatin right away, but I don't think that's the best way to do it. And if you look at the people that treat this a lot and have done a lot of it in the past, what they've started to do, a lot of them, is use more herbal therapies initially, and then rotate them too. Because if you use the same herbal therapy too long, the candida's really, it's smart, you know what I mean? It figures out ways to get resistant quickly. So if you keep giving something to it, pretty soon it's going to get resistant. And that's what I kind of seen with the diflucan and stuff. And I know that Teitelbaum, who I think is great, and he's did a lot of work on this, Jacob Teitelbaum, who wrote the book From Fatigue to Fantastic. But he talks about using diflucan for 6 months even, or 3 to 6 months. But you're going to get resistance now. You can't use it that long. And the yeast will get smart, and then it won't work. So you gotta rotate it, I think. And so I'll do that, and then sometimes you can go ahead and use a fluconazole and nystatin, but then rotate it back and forth, to get rid of the yeast. And, maybe every 3 to 4 weeks or somewhere in there is a good time span to rotate. All right. Now, the other thing is when you kill off the yeast, you can't get constipated, because if you get constipated, then basically you're not going to get rid of a lot of toxins that are dying in the dead yeast. They're going to be sitting there in the gut, and you're going to absorb a lot of them through your leaky gut, because your leaky gut still isn't fixed yet. And so the other thing that's going to happen is that the other yeast that's there is going to use it for nutrition. So the live yeast will eat the dead yeast. And so you really got to avoid constipation. So we got to work at that. And sometimes that can be a challenge, with people that have this, because they do have a tendency to get constipated easy. And so we do have to work at that. The other thing that may be helpful in this case, if they have a lot of constipation, and probably is helpful and, should be done, is colon enemas. And, that's a really good way to, get things going and get things cleaned out, because some people have been constipated for, years, and they really haven't had a great bowel movement, and people that have, chronic candida. So doing colonics can be really helpful to wash everything out. And there's different ways you can do colonics, but you can even put nystatin in the colonic, and put it up there. Or other herbal killing therapies, different ones. You could put caprylic acid, you could put berberine, you could put golden seal, or whatever you want in that colon lavage, and put it right on top of the yeast. So it works good that way, I think. So that's something to keep in mind. The other thing that you may need to do that, and a lot of people that have chronic candida, and you'll really see this a lot in autism kids and kids. The 4 A's, they talk about allergies, asthma, autism, and ADHD. Okay, so with these kids, and with adults too that have this, they'll have heavy metals. They'll have a tendency to retain heavy metals because their body won't get rid of them like they're supposed to. And so that will make it difficult to eliminate candida. And I'll tell you why that is. And this is going to sound kind of weird to you, but But Candida has been shown to actually take, well, one, I told you that it makes those biofilms and it incorporates the heavy metals into those so that you can't get at it. So it's got mercury like sitting on top of this film and it's back behind it, and you got this metal out here, this metal shield, you know, so that's one reason. And then the other reason is that Candida takes up the mercury into its cell. It actually will take it into the cell and into the cell wall, and it puts it right around its cell wall. And that actually, it uses that to protect itself. And the body will use that Candida to like keep the mercury from spreading. That's one of the theories, that it will use the Candida because the Candida takes the mercury and it walls it off, and it keeps the Candida out of the cellular matrix, out of the person's matrix or the patient's matrix, and it puts it out there so it's away from it, and so the body will like kind of want to keep it, and they'll want to keep Candida around. So getting rid of the heavy metals can be important, and that may mean that, you know, if a person has mercury amalgams, that, because that's a constant source of contamination, and, you know, if you don't believe that, you can look up the smoking tooth on the internet and look up the video, or you can talk to my friend Dr. Johnson. He'll instruct you on that, because it's definitely a big problem with mercury amalgams and yeast overgrowth and other problems. So that may have to be addressed. So remove, basically, like we're going to remove the organisms. Let's see, I need to go back here. Okay, so we're on replace. Okay, so replace. All right, so we talked about remove, and we're removing food allergies, removing the organisms, right? So the next thing that we need to do is we need to replace. Okay, so what do we replace? Well, one of the big things that is always a problem almost with people that have chronic yeast overgrowth is hydrochloric acid. So you're going to have low levels of stomach acid, and like we've seen, you know, initially I talked about the people that were on the chronic Prilosec treatment, chronic proton pump inhibitors. That leads to, you know, yeast overgrowth. And so people that have low stomach acid will get yeast overgrowth. And the problem is that, number one, a lot of people are low in acid for various reasons, and as they get older, they get a lot more lower. So that over the age of 50, I think at least 50% of people are low in hydrochloric acid, or they're getting low levels of stomach acid. And by the time you get to be like 80, it's almost a, you know, given that your stomach acid is going to be somewhat low. So, and then the other big problem we have is people using all the antacids, right? So it's $2 billion a year. So, you know, I mean, that's a big business. And so, you know, everybody, like they say that 75% of the use, too, is in heavy users. So only 25% of the people are using it occasionally. The other 75% are using it every day. And so they're using something over the counter, you know. And so what has happened with this is that since we started developing antacids, which I think were back in the 50s is when they first started developing antacids and marketing them, as people took more and more of them, they got more and more resistant, and they needed stronger ones, and so we keep getting stronger ones. Now the drug reps are coming in my office and trying to get me to prescribe these ones that last for 3 days. I'm like, block it out for 3 days, man. Let's, you know, go do whatever we want, eat whatever we want for 3 days. Just, you know, it's crazy. And so we're blocking all this acid out, and then we're creating all these big issues. You know, because number one, well, one thing is, you know, I mean, the FDA, like, you can go buy a box of Prilosec at, you know, at Steve's Pharmacy. I don't even know. You probably don't even carry that, do you? So anyway, or you can go to Walmart. Okay. So you can go to Walmart and you can get the box of Prilosec, and you can pull that little insert or whatever they have in there out. And it'll say that you're not supposed to take this for more than 2 weeks, you know, unless you see a doctor. And then it also says that there's a risk for long bone fractures, or for increased rate of fractures in people that take Prilosec for long periods of time. And the reason that is because this is exactly what it's doing. It's just like, it's blocking everything. all your absorption, all your nutrients. So if you don't have stomach acid, those are all nutritional things that you're going to be short in. And so you could name the disease, name the disease, and you're going to find that some of these deficiencies are going to be present in that disease, almost any of them. So, and especially the immune system gets affected big time by all this. And so when we have this low stomach acid, number one, the stomach acid serves as the first protective mechanism against yeast. Like if you take some yeast in, the stomach acid will like sterilize, any food, any yeast that's on the food if you have good amounts of stomach acid. But if you don't, then, the yeast is going to get by that stomach and it's going to get in the intestine where it can start to grow. And so that's the same thing with other bacteria. It's like a protective mechanism even against E. coli and stuff like that. And who knows, maybe that's part of the reasons we're seeing more outbreaks, of those type of things like E. coli and stuff because people's stomach acid is so depleted. And we know it has something to do with antibiotics too, but, that could be part of it. So they create, antacids create multiple nutritional deficiencies. So the first thing we have to do is we have to get the stomach acid corrected. We got to either replace it or I got to get them off the Prilosec, I got to get them off the Protonics, I got to get them off the Prevacid, the Tums that they're eating tons of because their healthcare provider said you need to take it for calcium. Which is, I don't know where that came from. I just don't get it. But anyway, I used to tell people that because they told me to tell them that. So, that's how it works, So nobody ever really thinks about it. But anyway, we shouldn't be taking Tums for calcium. And so we got to get them off that, and then we got to get the acid going better. But even, even the stuff like with the low stomach acid and the antacids, it's related to heart disease and stuff, too, because indirectly it could increase your rate of heart disease. So, just a minute here. Okay, so we want to replace hydrochloric acid. Then, and then the other thing too that you can replace here that I forgot to mention is digestive enzymes. So, you may need to use some digestive enzymes too in what you're going to replace. Okay, so remove. We already did that, right? Or did I go backwards? Okay. Yeah, all right. I kind of went over all that with you. And about replacing the stomach acid, just kind of how you do that. The thing with the stomach acid, the betaine HCl is what you use, and usually always you take it with food, okay? And sometimes people might not be able to take this right away, but, I use it in the nursing home, with some of my patients that have stomach problems, and it's pretty amazing that, it helps them, to take it with their food and stuff, and they feel better. I have one lady that has chronic stomach issues, and it's really hard to treat yeast in the nursing home. You can't put them on a yeast elimination diet. Forget it. It ain't going to happen. So, but, you can at least help them with some stomach acid sometimes. So anyway, so the betaine HCl, you take it with a meal, usually a meal containing protein. The other thing is one of the big signs of people that have low stomach acid is that they will get nausea like when they take vitamins. So if somebody takes vitamins on an empty stomach and they get nauseated, they probably have low stomach acid. And so that can be a thing that will help them there. All right, digestive enzymes, replacing those, yeah. These are just the different types of digestive enzymes, lipase, pancreas, the pepsin, and stuff like the pancreas. The pancreas secretes about 1.5 quarts of pancreatic juice, so that's a pretty big bunch of pancreatic juice when it's working right, okay? If it's not working right, then, you're not going to be getting adequate excretion of enzymes. So those have to be, you can test for it. This test is pretty good, is fecal elastase, and that will tell you if you have pancreatic insufficiency most of the time. And you can do a fecal fat analysis, but that test is a good test. All right. Repopulate. So that's the next thing, okay? So basically we remove, the pathogenic organisms. We replace, the main things we think about replacing are the betaine HCl and the pancreatic enzymes. You can also think about nutrition there, though, replacing those minerals and stuff that are lost that we know people are deficient in with low stomach acid. That's the other thing with the replacement. But then we repopulate. So repopulate, we're going to use probiotics and prebiotics. And a lot of times a probiotic will have a prebiotic in it. And the prebiotic is basically things that feed the probiotics. So the probiotics are good bacteria, right? There's several of them. That's also something that could be an entire another lecture. There's just tons of stuff on probiotics, and there's research being done on it all the time. There's it's just amazing, like what the bacteria do in our gut. Like we have more bacteria in our gut than we have cells in our body in a healthy gut. So, and those bacteria, not only do they suppress the growth of other things that shouldn't be there, they keep them in check, but they also produce products. They produce all kinds of things that even B vitamins, that we use, the bacteria produce. And they also produce these factors that communicate with our immune system. So they actually travel across the cell, the wall of the gut, and they go into the lymph nodes and the Peyer's patches, and they have these little chemicals that tell the immune system what to do. And that, if there's an infection in the gut, some of these good bacteria will send these messages to the lymph node and say, hey, there's a guy here, shouldn't be here, get out here now, get him. And they will. It'll send a message. And so when we disrupt those bacteria and everything, we really affect our immune response and stuff. So there's tons of stuff on that's coming out all the time. But anyway, basically with the prebiotics, so we give something to feed them like FOS, which are fructooligosaccharides is what they are. And they basically, the bacteria, it's just something for them to munch on. They like to munch on it, eat it, and makes them grow. Okay, so it's nutrition for the good bacteria. So they also help improve liver function, the prebiotics, the FOS. The probiotics, there's a lot of different probiotics you can use, but you should have both small bowel and large bowel bacteria. The lactobacilli are generally the ones that are going to be in the small bowel. So when we talk about acidophilus, everybody kind of knows what acidophilus is. That's a small bowel bacteria. It just happens to be one that's in fairly large numbers in the small bowel, but there's, a million more, It's just there's tons of them. We haven't identified even all the ones and what they do. But anyway, Lactobacillus acidophilus should be, or some lactobacillus, like Ramios is another one, which is good for the immune system. It does a lot of communication with the immune system. You should have that, and then you should have some large bowel bacteria. So the large bowel bacteria are like Bifidobacterium. And so Bifidobacterium, they also, are really important. They're really important for regularity, with colon health, with colon function, motility, and everything. And so they produce certain chemicals like butyrate. Butyrate is a fatty acid that's important for colon health, and it helps with movement of the colon and stuff. So you want to have, at least those two in there, species, and probably more. And then you should have at least, if you're treating Candida overgrowth, I like to at least have 20 billion, but, even more than that. In some cases, I even, will go up to hundreds of billions. It depends, they're using, for Crohn's disease and inflammatory bowel disease and colitis, they're using, trillion CFUs. But one of the things that you have to watch when you're doing this, if somebody has really bad leaky gut, and you give them acidophilus, they'll have an allergic reaction to it sometimes, or just a little dose will make them sick. They'll get nauseated and bloat. And if somebody does that, they have some leaky gut, because there really isn't any other reason for them to be doing that. So they're having some you have to get the leaky gut kind of under control. You can start at a low dose of the acidophilus and then gradually build it up with those patients, and then try to work on their leaky gut problem, and then you can get them on them. And if somebody has severely compromised immunity, like an AIDS patient, you don't probably want to give them a lot of live bacteria, because it can transverse the bowel and get into the bloodstream. Same thing with anybody, if they're really immunocompromised, like somebody who just got a ton of chemotherapy for cancer, I'd be careful giving them probiotics, because there has been cases where they've got septicemia and stuff from, good bacteria. All right. So repair. So that's the last thing, and that's where I talked about that increased GI permeability, and with that. That because if we don't address it, like the patient really isn't ever going to completely recover, and they're going to you're going to get rid of the yeast, like you use all these killing agents and the yeast is gone, and you've replaced the hydrochloric acid, you've given them digestive enzymes, and they still aren't better, and they follow the diet good. They say, man, I'm following the diet, I'm not eating anything off this diet. And they're still not better. So this is where the problem can be a lot of times, is you got to treat this part. All right. And even if they are better and stuff, you still got to address this, I think. So the increased GI permeability has to be addressed. And so different ways to, you're going to have increased permeability in the small intestine and also in some in the large intestine. So the small intestine, these are just some things. There's a bunch of stuff. There's all kinds of products out there that are for this, and there's some really great products that have, a mixture of these different things in them that you take every day. And I think just today I put like 2 or 3 people on different things to heal the small bowel, or to heal their increased GI permeability. So the other thing that helps, and like I've used this with some patients, and I know with my wife, like if she really gets into a bad thing, like if she ate too much, or she drank a bottle of whiskey. No, she doesn't do that. But anyway, if she sometimes she has to fast, and if she goes on a fast for a day or two, it'll really help get things back in check, because it does help heal the leaky gut. And so the WBC activity increases and when you fast, and it's more effective at removing the circulating toxins. And this has been shown to be true by research. They've showed this, and it decreases inflammation. So there is a reason to fast, and it can be helpful. So glutamine, is one of the base things that we use with this, and that should pretty much, I think, be in any formula, any treatment for increased GI permeability is glutamine, and glutamine is an amino acid, but it stimulates intestinal mucosal growth, helps prevent protein loss from muscle too, and it's an immune support. It increases IL-6, which is another one of those cytokines I talked about, and the IL-6 is actually a good one, and it supports the immune system. Not that any of them are bad. I mean, we have reasons for all these cytokines. I mean, but some of them just can cause damage when they're in high amounts. All right. So just summary, overgrowth of candida can cause a wide variety of symptoms in every system of the body. The GI, genitourinary, nervous, and immune systems are most susceptible. Patients with candidiasis have many of the same symptoms as those with chronic fatigue and often respond to treatment for chronic yeast overgrowth. Prolonged antibiotic usage is believed to be probably the most important factor for causing chronic candida overgrowth. Low stomach acid and leaky gut are issues almost always present and must be treated for long-term success. Can use the 4R program for long-term success and to prevent relapse. And you may have to treat underlying heavy metal toxicity in some difficult cases to prevent relapse. Okay. So that's all, and I hope that was helpful for you guys. I know there's a lot of stuff there. I kind of jammed a lot of stuff in, but yeah, Steve. Yeah. There's some references, like on the reference sheet there. That one by Crook is like the original book. That's really good. I mean, that's a good book to just start with. He also has one for women, because it is more common in women. Men do, it's probably 70-80% women, but a lot of there's more in men, but I think they just won't admit it. Yeah. Yeah. Well, if they can't tolerate the betaine HCl, then I think they have a baseline problem, and their gut is like so denuded. Like the mucus in their gut is really low, and they can't stand the acid, because they should be able to stand that, because when you look at how much is in one of those capsules, okay, how many of those capsules do you think your body makes when you eat a meal? Let's say you eat an average meal. How many of those capsules, like a betaine HCl capsule is 600 milligrams. It's about, it's so big or so. How many do you think you'd make? We'll take some guesses. 50? No, down a little bit. 35, but that's a lot, And we're only given like 1 to 4, So, we might give 6, in some cases, but if you take one of those and you burn, it's like, there's a problem, You've got a problem with your gut mucosa, I think. So you got to work on that. So how do you work on the mucosa? So basically you need to work on, the patient probably has a lot of nutritional deficiencies, number one, okay? Because if they've had that low of stomach acid for that long and they burn with 1 capsule of betaine HCl with a meal, then I know that they have nutritional deficiencies, because if we look at all those things that stomach acid affects, B12, B6, folate, all the B vitamins, zinc, chromium, molybdenum. Molybdenum also really good, for just an aside, is really good. It does kill candida, or you can use molybdenum. Yeah, and there's a paper on that. I had a paper on it. But anyway, it blocks, and it also blocks the formation of that alcohol to acetaldehyde, so that when the yeast is fermenting that, it blocks that fermentation step. So it helps with fatigue. But anyway, it was a pretty cool paper. I found that. I forgot to bring it up. But anyway, so you've got to think they have nutritional deficiencies. So you've got to start working on all of those, zinc, chromium, calcium, magnesium, iron, and that's the other thing with people with the chronic iron deficiency, that, that the doctor can't get their iron up, and they keep giving them iron. You can give them some stomach acid, and a lot of times it'll help bring it up. So anyway, because you need stomach acid to absorb iron. So they'll be deficient in a lot of things. So you got to work on their nutrition, number one. And those patients, some cases, they might need IV nutrition because their gut is bad. You could give them oral nutrition, but are they going to absorb it? So they may need to go into some IV nutrition, and that's like a big help for some of these chronic patients is to give them IV vitamins and minerals. And so the other thing is like using licorice, stuff like licorice, which increases the mucus layer on the gut. So I use like deglycerized. It has to be deglycerized. It can't be plain licorice. And of course, it's not the candy licorice you go buy. It's it's not going to help it. That doesn't actually even have licorice in it. Yeah. So anyway, you got to use DGL, and you can get chewable tabs. Sometimes those are good for that. But I think it's a nutritional issue. A lot of it. Mm-hmm. Yeah, they have terrible leaky gut, and so yeah, it's hard. And I think that I know that with that is one case where IV nutrition is really can be helpful with them if you can do that with them. And there may be other methods that people have, and like homeopathy maybe in some cases might be helpful too there. But I think that you really have to. The nutrition is the issue, and they've gotten so depleted that it's like, how do I get this stuff in them now? Because their gut's leaking like crazy, and they're getting toxins all the time, and they're malabsorbing, and the other thing, like I didn't mention, like you can do the leaky gut test, and that could be a useful test in some people. I don't usually do it. I haven't really did it much at all, because I usually just do it clinically, because I know the patient, if they have a lot of food sensitivities, they have a leaky gut, So, but it could be helpful to track it to see if they're getting better. And so the way you do that test is you give them mannitol, which is a sugar, And mannitol crosses the barrier really readily in a healthy gut. It's absorbed real well. And then you give them lactulose, okay? And lactulose doesn't cross the gut barrier. It's supposed to stay inside the gut. And it's really good for constipation because it stays in there and it causes, looser stools by drawing fluid into there and stuff because it's osmotic. And then it also feeds bacteria. Lactulose feeds good bacteria. It's like a probiotic too. So lactulose, you give them lactulose and you give them mannitol. So then the patient pees about 6 hours after they take a dose of that. Then you check their urine and you see what's in it. Well, there should only be mannitol in it because lactulose should stay in the gut. So if it has lactulose, then that means that their gut's leaking, And then you can also do a ratio on that. And the other thing that you can do is if they don't have any mannitol, or if they have low levels of mannitol, then what that would tell you is that they're malabsorbing, So it can sometimes give you a couple answers that way. But, whether it changes your treatment in the long run, and I don't know. You're still going to be looking at them clinically, trying to get them to heal and stuff, and looking at their gut. But you can do the test, and maybe I should start doing more of it. I don't know. I do so many tests, the lab doesn't like me anyway. So, okay. And my nurses don't like me either, because they have to put in all the orders. Yeah. Yeah. Yeah, absolutely. Yeah, and it's just like it's not really indicated to keep treating them with antibiotics. I mean, an acute otitis media. I mean, if you look at even the American Academy of Pediatrics recommendations, most of the people don't even follow those. And those are like probably level 2, maybe level 1 on how to treat acute otitis media. And how do they treat, if the kid is like over a certain age, like I think it's like a year, and they have fluid in their ears, and they don't have a fever, and they've only had it for 2 or 3 days or something, there's a cutoff, I don't know. You don't give them antibiotics. You wait for it and see if it will resolve. But how many times do they get? They get antibiotics every time. I mean, I don't know, and if you try to do it, sometimes I can understand because the parent or whatever is like, you gotta give him something, you see like he's doing, so, okay. But if you could maybe do something else, in some cases you could use like homeopathy, you could use something natural like berberine. You can even use some ear drops, some for pain. And I've seen people do that, and that will sometimes just be all they need for a little while, and then it'll resolve on its own. But if you start giving the antibiotics and you run into problems when you keep doing it, you get this, but you also, there's higher incidence of asthma, with chronic antibiotic use, and it's probably related to leaky gut, like everything else. Yeah. Yeah, well, a lot of times because of the leaky gut, yeah, they'll have gluten stuff going on because that's a big protein and they eat a lot of it, because they like that stuff. People that have yeast. So yeah, you will. Yeah, you'll get it. Yeah. Did anybody have any other questions? Or just like, okay, thanks. Yeah, all right, thanks.